Muscle injuries are a persistent challenge in professional sports, especially among athletes who rely on explosive movements. Hamstring injuries, in particular, have become increasingly common, now accounting for nearly a quarter of all injuries in men's professional soccer. Despite advances in rehabilitation, recurrence rates remain high, and recovery times can vary widely. This growing prevalence highlights the need for improved treatment strategies and a deeper understanding of muscle healing. In this video, we'll explore the latest research on platelet-poor plasma, (PPP), and platelet-rich plasma, (PRP), for muscle injury management, examining their biological mechanisms and clinical potential. Hamstring injuries are not only frequent but also notorious for their high recurrence rates. In men's professional soccer, hamstring injuries have doubled over the past 2 decades. These injuries often occur during high-speed activities like sprinting and kicking, and the risk increases with age and previous injury history. The location and severity of the injury play a significant role in determining how long an athlete will be sidelined. For example, injuries involving the intramuscular tendon can extend recovery times significantly. Understanding these factors is crucial for tailoring effective treatment and prevention strategies. The standard approach to muscle injuries typically involves non-operative measures such as rest, ice, compression, and gradual rehabilitation. Physical therapy remains the cornerstone, but persistent or severe cases may require additional interventions. Hematoma aspiration and platelet-rich plasma, (PRP), injections have shown promise in select cases, potentially accelerating recovery. However, the effectiveness of these adjunct therapies is still debated, and their use is often tailored to the individual athlete's needs and injury characteristics. The search for optimal protocols continues as clinicians strive to balance recovery speed with long-term muscle health. Inflammation is a double-edged sword in muscle healing. On one hand, it's essential for activating muscle progenitor cells and coordinating tissue repair. On the other, excessive inflammation can lead to pain, delayed recovery, and increased fibrosis. Nonsteroidal anti-inflammatory drugs, NSAIDs, are commonly used to manage pain and reduce inflammation in the acute phase, but their routine use is controversial. Oversuppressing inflammation, especially with certain medications, may actually hinder muscle regeneration. Understanding the balance between beneficial and harmful inflammation is key to effective muscle injury management. While most muscle injuries are managed non-operatively, surgery is sometimes necessary for severe cases, such as tendon avulsions or high-grade intramuscular tendon injuries. Surgical techniques like anchor fixation and suture repair can offer predictable recovery and a higher rate of return to sport, especially for athletes with demanding performance needs. However, surgery is generally reserved for cases where conservative treatment fails or when optimal functional recovery is essential. The decision to operate is based on injury severity, location, and the athlete's goals. Rehabilitation after muscle injury should be individualized, taking into account the specific sport, affected muscle group, and injury severity. Early recovery focuses on avoiding high-strain loads, with progression guided by symptoms and functional capacity. Eccentric exercises, such as Nordic hamstring exercises, have been shown to reduce return-to-play times and lower re-injury risk. Strength-based interventions, flexibility training, and proprioceptive techniques all play a role in enhancing muscle resilience and preventing future injuries. Deciding when an athlete is ready to return to sport after a muscle strain is a complex process. Objective criteria include pain assessment, strength testing, and neuromuscular control evaluations. Imaging, such as MRI, can help detect residual edema or incomplete healing, which may signal a higher risk of re-injury if return is premature. The goal is to ensure that the muscle can withstand sport-specific demands, and that the athlete has regained near-complete strength and function before resuming full activity. Skeletal muscle has a remarkable ability to regenerate after injury, largely thanks to satellite cells, specialized myogenic precursors located around muscle fibers. These cells are activated by injury and play a central role in orchestrating tissue repair. The extracellular matrix, ECM, also contributes by providing structural support and biochemical signals that regulate satellite cell behavior. Disruptions in ECM integrity can impair muscle healing, highlighting the importance of a healthy cellular environment for optimal recovery. Autologous blood products like PRP and PPP have gained attention for their potential to enhance muscle healing. PRP is rich in platelets and growth factors that promote cell proliferation and angiogenesis, while PPP contains fewer platelets but is rich in factors that modulate inflammation and fibrosis. The idea is to harness the body's own regenerative capabilities by delivering concentrated biological mediators directly to the injury site. However, the clinical effectiveness of these products is still under investigation. PRP contains high concentrations of growth factors like transforming growth factor beta and platelet-derived growth factor, which stimulate cell proliferation and new blood vessel formation. However, PRP also contains leukocytes and pro-inflammatory cytokines that may exacerbate inflammation, potentially increasing pain and delaying recovery. There's also a risk of promoting scar tissue rather than true muscle regeneration. The variability in PRP preparation methods adds another layer of complexity, making it difficult to compare results across studies. Platelet-poor plasma, PPP, offers a different biological profile. It is rich in insulin-like growth factor 1 and hepatocyte growth factor, which help modulate inflammation and reduce fibrosis. Basic science studies have shown that PPP promotes myoblast differentiation, encouraging the formation of new muscle fibers rather than just increasing cell numbers. This could mean better muscle regeneration and less scar tissue. PPP's ability to modulate the healing environment makes it an intriguing option for muscle injury treatment. Proteomic analyses reveal that PRP and PPP share about half of their protein content, but each influences muscle healing differently. PRP primarily promotes myoblast proliferation, which can lead to scar formation, while PPP encourages differentiation into mature muscle cells. The presence of leukocytes in PRP may also increase the risk of inflammation and complications like heterotopic ossification. These biological differences are crucial when considering which product to use for muscle injuries. Despite its popularity, clinical trials have shown mixed results for PRP in muscle injury treatment. Some studies report no significant improvement in return-to-play times or re-injury rates compared to standard rehabilitation. The lack of standardized PRP preparation and reporting makes it challenging to draw firm conclusions. While PRP remains widely used, its clinical benefits for muscle injuries are not consistently supported by high-quality evidence. PPP has been explored in a smaller number of clinical studies and case reports. Some athletes treated with PPP for muscle injuries have returned to play faster than expected, with imaging confirming injury resolution. A quasi-experimental study found that PPP led to a quicker return to sport compared to leukocyte-rich PRP, without increasing re-injury risk. However, the overall number of high-quality clinical trials remains limited, and more research is needed to confirm these findings. One notable risk associated with PRP treatment is heterotopic ossification, where bone forms in soft tissue. PRP's high levels of certain growth factors, especially bone morphogenetic proteins, may inadvertently trigger this process. Studies have shown a higher incidence of this complication in patients treated with PRP for core muscle injuries. In contrast, PPP has not been strongly linked to this risk, though research is still limited. A major challenge in evaluating PRP and PPP therapies is the lack of standardized preparation protocols. Variations in centrifugation, platelet concentration, leukocyte content, and activation methods lead to inconsistent product composition. This makes it difficult to compare results across studies and to establish clear clinical guidelines. Future research must focus on standardizing these processes to ensure reliable and reproducible outcomes. Regardless of the use of PRP or PPP, intensive rehabilitation remains the foundation of muscle injury management. Strength recovery, neuromuscular control, and sport-specific training are essential for minimizing re-injury risk and ensuring a safe return to play. Adjunct therapies like blood products may offer additional benefits, but they should complement, not replace, evidence-based rehabilitation protocols. The potential of PPP as a treatment for muscle injuries is promising, but more high-quality clinical studies are needed to establish its efficacy and safety. Researchers are also exploring how PPP and PRP can be best integrated into comprehensive rehabilitation protocols. As our understanding of muscle regeneration advances, new therapies may emerge that further optimize recovery and reduce the risk of re-injury. Both PRP and PPP offer unique biological advantages for muscle healing. PRP is effective at promoting cell proliferation, but its pro-inflammatory profile and risk of scar formation are concerns. PPP, on the other hand, may better support muscle regeneration by enhancing differentiation and modulating inflammation. However, current clinical evidence is limited, and neither product has been proven superior to standard rehabilitation alone. The choice of therapy should be individualized based on the athlete's needs and the specifics of the injury. When considering PRP or PPP for muscle injuries, clinicians must weigh the available evidence, the biological mechanisms involved, and the individual athlete's context. Factors such as injury severity, previous history, and performance goals all influence the choice of therapy. Ongoing communication between the athlete, medical team, and rehabilitation specialists is essential for achieving the best possible outcomes. Summary: platelet-poor plasma (PPP) and platelet-rich plasma (PRP) represent exciting frontiers in the management of muscle injuries. While PPP shows promise for enhancing muscle regeneration and potentially reducing recovery times, high-quality clinical evidence is still needed. Intensive rehabilitation remains the cornerstone of treatment, and future research will help clarify the optimal role of blood products in sports medicine. As our understanding grows, athletes and clinicians alike can look forward to more effective and personalized approaches to muscle injury recovery.